Good morning, everyone. Welcome to Sharpwave's podcast. I'm Parthvi Ravat, and today's topic is the recent guidelines released by the collaborative efforts of AEN, AES, and SMFM about people with epilepsy of childbearing potential regarding teratogenesis, perinatal, and neurodevelopmental outcomes after in utero exposure to anti-seizure medications. These guidelines were led by Dr. Alison Pack from New York, who is with us today, and we welcome her to the show today. Dr. Pack, would you like to introduce yourself?
Thank you for having me. Yes, I'm Dr. Alison Pack. As stated, I'm the lead person for this guideline that we'll be discussing, and I'm a professor of neurology at Columbia University in New York.
So let us start with the first recommendation, which concerns joint decision making. The guidelines emphasize joint decision making in people with epilepsy of childbearing potential. So, how important is it when we select an ASM, dose their ASM, and what should we consider before making those decisions?
Joint decision-making is critical to the care of the individual as well as the relationship between the provider and the individual. When choosing an anti-seizure medication for a person with epilepsy of childbearing potential, you need to factor in multiple components: seizure control, notably control of convulsive seizures. Convulsive seizures, whether that be generalized tonic-clonic seizures or focal to bilateral tonic-clonic seizures, are associated with potential risks for both the mother as well as the developing fetus. Side effect profile and long-term implications of treatment. Those are all factors that one needs to consider when choosing and dosing an anti-seizure medication. It's very important to, as I said, to engage in shared decision-making to not only address all of the above, but help the person with epilepsy of childbearing potential understand the implications of anti-seizure medication selection and dosing on reproductive outcomes, which was the focus of this guideline.
So then, before getting pregnant, what should we counsel as clinicians to our patients regarding major congenital malformations and intrauterine death?
Before we get into this topic, I do think it's important to highlight that most persons with epilepsy of childbearing potential will have normal, healthy babies with a low risk of major congenital malformations. I think that's a very important message to relay to the individuals that we treat. Among anti-seizure medications with available data, we found the following: lamotrigine, levetiracetam, and oxcarbazepine were associated with the lowest risk of major congenital malformations overall. I would like to draw your attention to the recent publication of EURAP Major Congenital Malformation Outcomes that was published in JAMA in March of this year. Findings in this study support our conclusions, and these are the highest numbers from a single registry when looking at different anti-seizure medication exposures in pregnancy. Valproic acid is associated with the highest risk overall. We found no clear increased risk in our analysis when comparing polytherapy to monotherapy. Valproic acid is associated with the highest risk of neural tube defects at 1.4%. Phenobarbital, the highest risk of cardiac malformations at 4.4% when compared to other anti-seizure medications. Phenobarbital and topiramate, the highest unadjusted risk of oral and cleft palate at 2.2% and 1.4% respectively. And valproic acid associated with the highest urogenital malformations, the highest risk of neurogenital malformations at 1.2%, and renal malformations at 1.4%. When looking at intrauterine death, the prevalence of intrauterine death did not differ across anti-seizure medications.
You've spoken about a lot of individual drugs. One of the long-standing drugs which we've been using a lot is valproate, and recent guidelines from Europe and the UK have specifically stated that valproate should not be used in patients of both males and females less than 55 years of age unless two independent clinicians independently assess and document that there is no other effective or tolerated treatment for those people. So what are your thoughts about this, and how is the difference with what you have suggested in your guidelines?
In our recommendations, we state that clinicians must avoid the use of valproic acid in persons with epilepsy of childbearing potential to minimize the risk of major congenital malformations or neural tube defects if clinically feasible. Clinicians must counsel persons with epilepsy of childbearing potential when considering or starting valproic acid that the risk of any major congenital malformation is highest with valproic acid when compared to other standard studied anti-seizure medications. And that's not something we've specifically discussed, but we did find an increased risk of neurodevelopmental outcomes in association with valproic acid. So in order to reduce this risk, clinicians must avoid valproic acid. These are all the highest level of recommendations, that is level A recommendations. We also state that valproic acid, you should avoid valproic acid to minimize the risk of small for gestational age and to minimize the risk of urogenital and renal outcomes. These are level B recommendations. Throughout these recommendations, we state if clinically feasible. Why did we include this? We included this because for some individuals, valproic acid is the treatment of choice in order to control convulsive seizures, particularly in persons with drug-resistant idiopathic generalized epilepsy. We all have those individuals in our practices whereby valproic acid is the only medication that controls the convulsive seizures. I'm concerned that the EMA and UK restrictions may be putting some individuals at risk of having seizures. In addition, when you step back and think about it, the EMA and UK restrictions view that all females or persons with epilepsy of childbearing potential will have children. Essentially, it considers those people only from the perspective of their having a uterus and potential to get pregnant. They do not factor in or consider other factors or life choices. In this guideline, we do not specifically address males as the focus was females or persons with childbearing potential.
Really a fresh perspective and a lot of food for thought that these guidelines might not be inclusive to everybody around us. So then now coming to once you get pregnant, one of the recommendations says priorities during pregnancy. So once pregnant, what should be the main focus about how to avoid convulsive seizures during pregnancy?
So it is important to maintain seizure control, notably convulsive seizure control. How does one accomplish this? Well, you follow concentrations if available. I recognize that not all regions of the world have access to anti-seizure medication at drug level monitoring. And as such, one needs to consider adjusting doses. The AEN, AES, and SMFM are currently putting together a protocol to address this issue in particular, a protocol to create a guideline. And this will be done under the leadership of Dr. Mark Kieser in Montreal.
Right. We look forward to those guidelines. Should be a good roadmap for clinicians all across the globe. What screening and intervention measures are recommended for pregnant females during the 9 months of pregnancy and thereafter for various defects related to ASMs?
I recognize as we discuss this that there are variable international practices regarding this. But let me go through what we specifically recommended in the guideline. We recommended detailed anatomic ultrasound if available, as this ultrasound will detect most major congenital malformations. These ultrasounds are typically done between 16 and 20 weeks gestational age. For persons taking phenobarbital, we recommend screening cardiac investigations. As discussed, we find increased risk of cardiac malformations in association with phenobarbital use in pregnancy. Typically, this is done with fetal echocardiography. For persons treated with valproic acid or topiramate, we recommend screening of fetal growth. This can be done crudely with maternal weight, measurement of the height of the uterine fundus, ultrasound, and combination Doppler studies. All of these can be used to monitor the fetal growth. We also recommend age-appropriate developmental screening for all anti-seizure medications. The testing will vary depending on age and other international variables. These screening mechanisms are important because, as for any child who potentially has developmental delays, it is important to screen and get early intervention. So these are the recommendations one should consider, as you state, during pregnancy and when following the child in those early years.
We already know that neural tube defects occur during the initial phase of pregnancy, but is there any data on the occurrence of poor neurodevelopmental outcomes and the timing of intake of anti-seizure medication?
Really good question. And essentially, what we don't know specific mechanisms, so to speak, but we do know that brain development occurs throughout the entire pregnancy. When thinking about major congenital malformations, we really focus those in the early part of the pregnancy, whereas brain development occurs throughout, as I said, pregnancy. And in our analysis, we find that folic acid supplementation in the periconceptional period, as well as throughout pregnancy, is associated with a lower risk of adverse neurodevelopmental outcomes, such as autistic spectrum disorder and IQ. And therefore, it is important to take folic acid supplementation throughout the entire pregnancy.
So we're clear about the timings, but there is a lot of controversy regarding the dose of folic acid and some benefits versus risks related to cancer and folic acid. What are your thoughts about it?
The folic acid question was one that people really had a lot of interest in, and I think it was one of the most eagerly anticipated outcomes of the guideline. You know, what is the optimal timing? What is the optimal dosing? So let's just step back a little bit and address the findings for folic acids overall. The evidence does not support a reduced risk of major congenital malformations in children of persons born to epilepsy of childbearing potential exposed to anti-seizure medications. So why is that? Why do we not see that? Folic acid is actually supplemented and has been supplemented in over 60 countries throughout the world in grains and cereals. In the United States, it's been supplemented since 1998. And when you step back and look at the overall risk of major congenital malformations in the general population and neural tube defects in particular, you find that the risk has reduced. And therefore, for the individuals we treat, they are likely getting enough in their diet to override, so to speak, any potential benefit in reducing the risk when looking specifically at major congenital malformations. As I mentioned earlier, though, the evidence does support the folic acid supplementation reduces the risk of adverse neurodevelopmental outcomes. Specifically, it reduces the risk of autistic traits and is associated with a higher global IQ. So given that, what is the optimal dose? Well, we had hoped to clarify the optimal dose. Unfortunately, the data does not support a recommendation beyond at least 0.4 milligrams per day. Some of the most rigorous studies evaluating the effect of folic acid grouped individuals by whether they were taking a folic acid or not, and were not able to provide data on the specific dose. One study, a Scandinavian study, does support a reduced risk of autistic traits if given in the preconceptional period. We have not been able to define the optimal dose, but it's very unclear if high dose is necessary. And when you look around the world, there are variable practices. In the United States, for example, we tend to give less folic acid than they do in countries in Europe. And there was a study that was published. It was an analysis from Scandinavia of over 27,000 children born to people with epilepsy. And what they found was that exposure of greater than 1 milligram per day was associated with a 0.9% absolute risk of childhood cancer, notably CNS and blood-borne cancers, before the age of 20, resulting in a hazard ratio of 2.7. I will say, when you look at that analysis in more detail, that risk was skewed more towards the higher end. And certainly the findings from this study need to be reproduced. And I know many individuals have had some concerns with this. So I'm not here to support that, but I do think the findings from this study raises the question that too much folic acid may not be beneficial to the developing fetus.
So then what are the critical areas of research in the management of epilepsy in people of childbearing potential?
I think the one thing that we just talked about is we really do need better clarification of the optimal timing and dose of folic acid supplementation. That is one thing that we need to address better. We need better understanding of the understudied anti-seizure medications. We were not able to draw any conclusions in our guideline on lacosamide, and increasingly people are using cenobamate, of which we have no information. We need better understanding of the polytherapy impact. As I mentioned earlier, we did not find an independent risk of polytherapy, but polytherapy is complex, depends on the specific agents used, and the specific dosing may also be a factor. And we touched upon developmental or some screening. Well, we need to understand the impact of screening on fetal anomalies, major congenital malformations, and fetal outcomes, such as neurodevelopmental outcomes. So we need to have better understanding of that.
Before finishing off, do you have some personal anecdotes from your practice where you faced a challenge and then some challenges, some successes in managing patients with epilepsy?
Let's touch upon the valproic acid question. And, I did allude to the fact that some individuals need that the valproic acid is the main is the only medication, so to speak, that controls their convulsive seizures. So I do have certain people in my practice whereby that is the case. And in those individuals, what I had chosen to do is have them on valproic acid at the lowest dose possible. And then I'll use other medications. I saw one woman recently, she's on valproic acid at a level is around 40, and that's actually has dropped during pregnancy. She takes, in combination with that, lamotrigine as well as levetiracetam. And she's in the 3rd trimester. The baby has no major congenital malformations. And we are obviously going to be following, or the pediatrician will be following that child closely for any neurodevelopmental outcomes. And her husband and I had a very long conversation about that the other day. So that is a tricky case whereby I have to factor in seizure control as well as potential effects on the developing fetus. As we talked about, most individuals will have normal, healthy babies. And I can think of 2 particular cases that show each end of the spectrum. I had one woman that I took care of in my practice on relatively low dose lamotrigine. And in the 1st trimester, was found through screening that her baby had a major congenital malformation that was incompatible with life. So we had a long conversation about that, and in terms of future pregnancies. She'd done well on lamotrigine, and we had a discussion about, well, does that mean it was the lamotrigine? And the answer to that is Likely not. I mean, as we've discussed, lamotrigine is associated with the lowest risk of major congenital malformation when compared to other anti-seizure medications. And therefore, in treating her and taking care of her through future pregnancies, I'm happy to say that she went on to had two children, two successful pregnancies, and was on lamotrigine. Another thing to think about is, I had another patient that I can think of who I was not interested in getting pregnant, was not at risk, so to speak, of getting pregnant, and then came into my office pregnant. She was on multiple anti-seizure medications. She had been on folic acid. I'd taken care of her through adolescence, and I always had her on folic acid supplementation. And I'm happy to say that despite being on multiple anti-seizure medications, including a relatively high dose topiramate, she also had a normal, healthy baby. As I said, that we want to work together with the individual to reduce the risk of major congenital malformations. But please keep in mind that most people do have normal, healthy babies. And as stated, I do believe very strongly, specifically in avoiding valproic acid. I don't want anyone to get the idea that I think it's okay to use that. I strongly avoid using valproic acid and do everything I can. It is not a first, second, or third line agent in my practice for persons with epilepsy of childbearing potential, and I do everything I can to either not start it or remove it if they're already on it.